Welcome to my YouTube channel. Today I'm going to talk about ptosis. So ptosis, this is a drooping of the upper eyelid. As you can see in this picture, this is our normal eye and this is the drooping of the upper eyelid. So the muscles involved in the elevation of the eyelid are two, the levator papillaris superficialis, and we have the molars muscle. Levator is supplied by oculomotor, the molars muscle is supplied by the sympathetics. So it can occur either unilaterally or bilateral, that is the both eyes, and can range from mild to severe and sometimes actually obstructing vision. So classification of ptosis, we have congenital and we have acquired. Congenital is usually most commonly unilateral, while less acquired usually develop later in life and is due to various causes. So the types of ptosis, we have neurogenic ptosis. As we said, the elevation of the lid is done by two muscles, levator, and it's also done by molars. Levator is supplied by oculomotor, molars is supplied by the parasympathetic. So inhibition of either of the two will result to neurogenic ptosis. So we can have that cranial nerve oculomotor palsy or Horner syndrome. This is disruption of the sympathetics, and we can also have myasthenia gravis. This is when you have a disruption between the neuromuscular junction. So the key features of each one of them, we have in cranial tree palsy, you will have ptosis. You will also have downwards and outwards of the eye, and the reason behind this is because oculomotor also supplies extraocular, the four out of six of the extraocular muscles. So the two which it does not supply usually do downwards movement of the eye, that is the superior oblique, and outward movements of the eye, that is the lateral rectus. We can also have brown pupil. I have a video on cranial number 3 pupil, cranial number 3 palsy. You can go and watch it. Next is Horner syndrome, which will have a triad of ptosis, meiosis, and anhidrosis. In Horner syndrome, we have disruption of the sympathetics. I also have a video about that. You can go and watch it. Myasthenia gravis, this is when you have vertigable ptosis and usually worsens in the evening and usually improves with rest. So myogenic ptosis is when you have a problem with the muscle, which could be congenital myopathy, myotonic dystrophy, oculopharyngeal muscular dystrophy. So in congenital ptosis is when you have it is present since birth, and this is weak levator function. You can also have myotonic dystrophy. This is when you have ptosis and progressive muscle weakness, and you can also have oculopharyngeal muscular dystrophy. This is when you have ptosis, and because it also involves the pharynx, you can have dysphagia. Aponeurotic ptosis is when we have disruption in the aponeurosis of the levator. So this is usually involuntary and usually associated with aging. So majorly the elderly patients. Aging-related levator dehiscence. So it's most commonly in the elderly, and good levator function, however, usually have weak tendon attachment. So the next one is mechanical ptosis, when you have a heavy eyelid that even elevating the eyelid is difficult. So this is when you have maybe eye tumors such as neurofibroma, or you can have chalazion. You can also have severe dermatochalasis. This is excess skin. This is excess eyelid skin. So in key features, this is usually heavy eyelid causing ptosis. It can be unilateral and can be bilateral. Traumatic ptosis, this is usually because of levator aponeurosis injury, and this could be due to blunt trauma or surgery. So the patient will come in with an issue of trauma or an eyelid surgery. Clinical presentation and diagnosis. Currently know that ptosis is a sign or a symptom that a patient will come and tell you that my eyelid is drooping, or I cannot elevate my eyelid, or you as a clinician, you can actually see that this eyelid of this patient is actually drooping. So clinicals, what are you going to see? Drooping of the eyelid, which you said could be unilateral or bilateral. In addition to that, this patient will have difficulty keeping the eye open, and because we are straining to look, or we have eye strain, we will have forehead wrinkling. This is because of the compensatory mechanism of the frontalis muscle, and we're also going to have impaired vision in severe cases. So considering if this eyelid actually droops severely, then will impair vision. So treatment, as we said, ptosis is a sign or a symptom, meaning you have to treat first of all the underlying disease. And non-surgical treatment, we have you treat the underlying cause of treatment. We will start with myasthenia gravis, which is a chronic autoimmune where we have antibodies against the acetylcholine receptor at the muscular end of the end plate, and you give acetylcholine esterase inhibitors to prevent degradation of acetylcholine, that is pyridostigmine. You can also give steroid because it's an autoimmune disorder in addition to immunosuppressants. Horner's syndrome, you treat the underlying disease. This is when you have disruption in the sympathetic system. This could be due to a tumor, that is the Pancoast tumor, so the patient will come in with coughing, or it could be carotid dissection, which is an emergency. In addition to that, oculomotor palsy, so this is you observe and or treat the underlying disease. Oculomotor palsy is kind of divided into two, with the compressive part and the ischemic part. So if it's ischemic part, you could observe. If it is compressive part, which is an emergency, you can do an MRA, that is angiogram, in case of an injury to rule posterior communicating artery aneurysm. So in addition to that, you can also do ptosis scratch or eyeglass attachment, and this is for mild cases. So surgery is preserved for mild to severe cases, that is surgery is the male treatment for moderate to severe cases. Sorry, moderate to severe. Mild cases, you can do a ptosis scratch. So the type of the surgery usually depends on the levator function. So this is kind of a repetition, the differential diagnosis of ptosis. We said congenital ptosis, which usually most commonly, however, we can also have bilateral and is associated with poor levator function. Aponeurotic ptosis, which is usually most commonly bilateral, and it is seen in the elderly, and this is usually worsened with time. And the reason behind this is because of poor attachment of the levator muscle. However, we have good function of the muscle. Oculomotor palsy, which we have severe ptosis, and the ptosis is usually accompanied, it can be or may not be accompanied with dilated pupillary. However, the eye is usually downward and outward deviation of the eye. Horner's syndrome is usually because of disruption of the sympathetics and is usually mild, and you're going to have a triad of ptosis, meiosis, and anhidrosis. Myasthenia gravis, which is said is fluctuating and usually worsens with fatigue, and however improves with rest or an ice pack. Myotonic dystrophy, it is usually progressive bilateral, and it is usually accompanied or associated with ptosis, limb weakness, and you may have delayed muscle relaxation. Mechanical ptosis is usually viable, and this is when you have an eyelid mass, which could be edema or scarring, or a mass such as a tumor. Thank